Hi, we're back with Chapter 16, Part 2, and we're talking about the communication process. We've already gone through steps 1, 2, and 3, and we now are on step 4, listen to the response. When we look at listening, we need to remember that this is an active process. Listening is not passive. So, it requires us to really concentrate on what the patient's saying. We give our patient our full attention. We're not trying to document or take vital signs or get something ready for an exam while we're talking with a patient. And we need to be observant. We need to look at our patient and recognize that there may be something going on that they may not be telling us about. So we talked a lot about nonverbal communication in the last step, and this is something we need to look for. Can we tell there's something else on their mind that they may not be saying, or maybe they're giving us some clues but not the whole thing? And we need to be able to observe and see if that may be the case. One of the things that you need to know is when we talk about active listening, it's actually called decoding. So when the sender is giving us a message, and we would be the receiver, we really have to listen and decode that message to make sure we're getting what the patient said correctly. If we don't agree with the patient, that's okay. We can agree to disagree, but we do not argue with the patient. We do not let our thoughts get in the way of what the patient's saying. You need to focus our attention on the patient and not focus on thinking up a rebuttal in your brain or an argument. Stop and think a minute when you're having an argument with your child or your husband or spouse or friend or whoever. You know the minute somebody says something to you, you know if you're active listening or not. Because if you are truly active listening, you are not sitting there thinking, well, I can't believe he said that. And I remember he did this and he did that. And you are processing in your brain a response to come back. That's when we get defensive and we're not listening. We are hearing, but we're not listening. So, when we ask the question, what is the most important characteristic of active listening? Is it taking notes while listening? Maintaining eye contact with the speaker? Or focus fully on what the speaker is saying? So, you might think, maybe there's a couple there, but the best answer for this is focusing fully on what the speaker is saying. You just need to listen, leave your biases outside the door, and truly listen to what the patient's saying. So, number 5 is asking for feedback. So let's say we get a message and we really don't understand what that message is. So we have to try to figure out a way to send a new message to clarify what that person means. And there's a number of ways we can do this. So the first one is paraphrasing. Paraphrasing is taking what you think is said and putting it in your own words. So your book gives great examples of this on page 346. So their example is, I understood you to say that you had experienced these headaches every day for the past 2 weeks. Is that correct? So again, what we're doing is clarifying the information we think we heard. Okay? The second thing is reflecting. And with reflecting, what we're doing is prompting the receiver or the sender or whoever to complete or add to the original message. So again, we're asking them to add a few more details that might clarify our message. So again, the book has a great example of this that would be saying, you say that it's difficult for you to do exercises the therapist has recommended because, and then leave a blank for them to finish. Make sure you're leaving time enough for them to respond. You've asked them a new question, and sometimes people need time to formulate the answer. We don't want to document something that we think the patient is saying when that might not be accurate. The third type of feedback is asking questions. So that's, again, requesting clarifications and additional information. So people use words that we all have a different meaning for. So we're going to say painful. Well, pain to me, remember, pain is subjective. So pain to me may be that I have been run over by a Mack truck, where somebody else has a splinter and they may feel that's pain. So we need to get a little bit more information on what they mean by those terms. So the question that you can ask is, what symptoms are you experiencing when you say you're feeling terrible? So we're asking that question to get additional information to be able to describe what's going on with that patient in a much better, clearer format. The last one is requesting examples. And I love to do this because sometimes I really don't know where people are going. And so I, in my mind, have an idea of what they're saying, but I always ask for an example. And usually what I find is that my example was nowhere close to what they were trying to tell me. So in the situation that they talk about, they say, tell me about the kind of situations where you feel lightheaded. Is it something you're doing? What's going on? And I think that that really helps them be able to formulate and think about what's happening at that time. Are there things that are making me lightheaded? Is it just after I exercise? Is it after I get out of the shower? Is it, when I go up and down a flight of steps? What might be the reason that this is happening? Step 6 is evaluate the encounter. And when we talk, go back. So, I always forget the questions. I hear you saying you feel better after you've done the exercises I taught you last week. Is an example of paraphrasing, reflecting, or asking a leading question. Take a minute to think about that. And it is paraphrasing, because what we did was we listened to what the patient was saying, and we put those thoughts in our own words and responded back to the patient with that. Okay, so now we're going to do evaluate encounter. This is going to determine if our communication goal was met. And truly, we should be evaluating everything we do. We evaluate, boy, I didn't do that well. I'm going to use the example of discussion boards, okay? I introduced them into this class. I realized I let you guys try them. I realized how much you were struggling with them because I didn't set them up right. And I made the choice then because I evaluated the situation. I said, I'm not doing this anymore because I don't know exactly what I'm doing. I'm making your life more difficult. And right now, I don't think it's the best choice. So we do this evaluation process all the time, not just with communication, but in pretty much everything we do. So what we'll do is, let's say the patient says, well, I have pain, and you say back to them, well, can you explain the type of pain you're having? Is it a dull pain, a sharp pain? And the patient listens and then answers you, well, I think it's maybe more of a sharp pain. And we can go on and on by formulating either more questions or being able to maybe look at that and say, okay, so just sharp pain, or is there pain all the time? Well, now that you said that, maybe there's usually always pain, but sometimes it just comes through really sharp. So again, we're evaluating what they say. We're going to assess that, and then we're going to see if we need to continue on with that conversation. Communication through the lifespan. This is really important because we're going to be dealing with people from newborn to death. So from birth to death, sometimes pre-birth. So every time we deal with people at a different stage in their life, we have to be careful how we communicate with them. So let's talk about children. So when we talk about children and adolescents, we need to make sure we're reducing the fear. Think about a little kid. I think of my grandson Jackson when he goes into the doctor. He remembers he's getting a shot. And when they come in, people, he's sitting on the table, they're looking down at him, and he's feeling very, very intimidated. And so what I've seen them do, and what I would always do when I worked with children, is I would come down to their level. I would sit in a chair if they were eye level to me, or, squat down and talk with them, but I met them at the level they were at, because that way you're bringing yourself to where they are and they don't feel quite so intimidated. That's really important. The other thing that we can do is we can actually do play acting with children. So let's say you need to get a blood pressure on a child. I'm going to tell you it's one of the hardest things that you have to learn how to do, because no 3-year-old is going to let you put on a blood pressure cuff and be quiet in the middle of the doctor's office. It's really difficult. So sometimes if we go and take one of the little play doctor kits and get that blood pressure cuff out and show them how it works and say, now what I'm going to do when I squeeze this ball over here, I need you to squeeze that on the one you have. And it works really well when you try to get them to play as you're doing the skill. Adults are different. When we talk about adults, we can't assume all adults understand what we're saying. We have talked about this through this whole chapter. People are on different levels. And so when we're talking to adults, we need to be very careful and pay attention to what they're saying to us, to see maybe if they're struggling reading something we've given them. And so we need to be observant. It goes back to that active listening piece. Adulthood, again, is the time sometimes, and many of you have this right now, is they're called the sandwich generation. And so you have children, but you're also dealing with the parents. And so you're not only having to deal with work and everything else, but you have kids you need to worry about, and now you have parents that you have to be worrying about. So we need to make sure that the patient is in a good place. Again, if mom's sick and they're trying to find care for mom and the 2 kids are sick at home, we have to be able to pay attention to that and see if there's anything we may be able to do. This is when maybe home care would be a good option for people to say, would it be helpful if we talk to the doctor about having somebody come in to your mom and dad's house? Would this be something that would be useful for you to be able to help you have a little bit more time to do the things you need to do? So it's going to be really important, again, to ask those type questions, but also make sure you're saying things so they understand it. And this is where medical terminology comes in. We love to overwhelm people with our talk. And we don't do it purposefully, to be quite honest. We just are so used to doing what we do that we forget not everybody understands us. So we really need to pay attention to what we say to people, because if we're using medical terminology, most people are not going to understand what we're saying. We need to put it in a way that someone who's in the 8th grade can understand that. The best way to find out if these people understand what we're doing is use something called the teach-back method, the teach-back, to check understanding. And when we talk about that, it's where we're going to tell them what they need to do, and then we're going to ask them to repeat to us what these steps are involved in doing whatever we've asked. So let's say we've asked them to do an insulin injection because they've just been diagnosed as a diabetic and they have to take insulin. We're going to walk through step by step what they need to do to give them an insulin injection. But what we want to do is then have them walk through that to make sure they've understood every single thing we've said. And it really is a very good way of teaching the patient. Older adults, I love older adults. These are my favorite people to work with. The one thing we need to think about with older adults is there are some people that are 95 and are as sharp as a tack. And then there's some people that are 65 and they're starting with dementia. So we have to remember they can be all over the place in their cognitive ability, as well as if they have chronic illnesses. So we need to remember that. The other thing we need to make sure is we're talking to them in a respectful tone. We do not need to yell at them. I'm really bad at this. When I see older people, I always raise my voice. And my dad used to yell at me all the time about that. Quit yelling at me, Lisa. So be respectful. Make sure that you're talking slower, because it does take a little bit of time sometimes for older people to get that, hear the message, get it to their brain, process it, and then be able to say something in response. So be respectful and give them the time they need to answer. There are a lot of different age-related topics that are out there, and we need to know a little bit about them and maybe help them through that. One of the things that they ask about is having sex, and all the young people go, oh my gosh, but they are still sexually active. And so we need to remember that. They may ask questions about that. They may ask questions about their chronic disease and how it's going to affect them. What are these medications going to do to me? Are they going to make me depressed? Are they going to make me tired? Is it going to decrease my libido? What are they going to do? And that's important for them. And we need to remember that. You also can they may talk about when they get to the age where all of their friends are dying, they may start to really go into a depression. And it's very difficult to them because they know that all of their friends are leaving them. And, they realize, what, I'm not far away. So some of these things we need to be able to talk about and feel comfortable with as we talk with our older patients. There are a number of barriers to communication, and they can absolutely block effective communication. So they've listed a few of them here. Language differences, cultural differences. I have to tell you a funny story. It's actually not funny. It is now, but it wasn't funny when we were having it happen. I worked in an OBGYN office, and this little lady, and I knew her because she worked at the Chinese restaurant here in LaVale, came in because she was pregnant. And she had her first appointment, but she spoke no English. So here are three people, the doctor's wife, me, and one of the nurses, trying to talk to her. And we were using our hands. We were trying to draw pictures, and we got so exaggerated with our movements, and, our inflection and our tone was all over the place. And we looked around, and every staff member was looking at us, and they just busted out laughing. And later they said, "Do you know how ridiculous you looked? That woman had no idea what you were saying, and the three of you looked like crazy women." Well, we finally figured out if she could call someone who knew both languages, that we may be able to develop some communication. And she did, and we were able to talk that way. We took her back into a private room, and this person, after she agreed that they could hear some confidential information, we were able to get the information to and from. What happened with that patient is she went back to family in DC, where there were physicians that spoke her language. And I would be, as a physician, very uncomfortable to try to work with somebody who had no idea what I was saying. And so those are some of the things that we look at with the language differences. Again, cultural differences. This is a real big issue, and we've talked about this. Maybe the man talking for them. Maybe we don't believe in that, the cultural thing that they're doing. Dress is a big thing. We have a lot of people that come from the Middle East, and they're covered from head to toe. Well, they come into the doctor's office, and what is the first thing that we ask them to do? To remove all of their clothes and put this gown on. Well, they won't do that. That is against their culture. And so what we have to do is learn how to work with that patient around the garb that they're wearing. And that's really important. Defense mechanisms we are going to talk about in detail when we hit chapter 15, because those are things that you need to be aware of, and we do these every day. Sensory impairment and physical distractions, again, those are things that we see. So again, physical distractions, it may be cold. It may be that, they give you a 2-inch step to crawl on top of a table and you're worried about falling off. The sensory impairment, maybe you can't hear as well, maybe you can't see as well, and those all can be a barrier when talking or working with a patient. And the last two are medication effects and pain. And when we think about medication effects, I think of pain medicines. If you've ever had surgery, you take pain medicine and man, you are out. You don't remember a lot of what went on. And so when we have patients that are on these, Schedule II medications, we have to realize that they may not be able to communicate well. As well as that pain, when patients are in pain, it is very difficult sometimes for them to talk. And they can be very short and snappy because they're not feeling well. So all of those things can become barriers in the communication process. Special needs patients. These are, again, this is going back to the pain medicated. They need to identify themselves, and we say their name. This is really important. We had a patient come in one day, and we called a person's name, and this lady came in. They asked her name again, did not ask her date of birth. She only gave her first name. We went through this whole appointment, And when she got out to me, I was working checkout that day. I said, well, Mrs. So-and-so. And she looked at me and she said, well, that's not my name. And I said, well, what is your name? And she said, well, it's not that. And I said, well, could you tell me your name? And she told me, and here the woman was higher than a kite. She just stood up when a name was called. And the lady it was the patient just assumed that the patient had the same name. So this patient went through a whole exam and whole, rigmarole through this and got to me, and we realized we saw the patient for the wrong thing. So it's very, very important that we identify our patient. Again, we're going to want to speak slowly, maintaining eye contact, short, simple messages. If we need to repeat the information, we can. If it is appropriate, we can use touch. And you need to be very careful with this. You can tell if somebody is comfortable if you touch them. People in the United States have about a 3-foot personal space. I've known people, sorry for the clock, by the end of this online session that we're having to teach from online, and I'm doing this from home in my dining room, I think I'm going to shoot the clock. Anyway, I think that might be the one thing that doesn't make it through COVID-19. But anyway, so when we're talking about these patients with special needs and touch, be very careful. If you're going to touch someone, watch for their immediate response. If someone is uncomfortable with touch, you will see them actually retract away from you. So it really is important that you watch about touching. The other thing is, there are some times when we're scheduling appointments, make sure we're trying to schedule them at the right time that's best for them. I remember when I had my knee replacements done, I knew what my schedule of pain medication was going to be, and I wanted to try to get to where I needed to be like a half hour after I took the medication, because I knew I was going to be in the least amount of pain at that time. I didn't want to have to wait until the pain medicine was wearing off. So it really is important that we think about those kind of things. So different types of patients that we're going to work with that have special needs. Again, patients suffering from dementia or Alzheimer's. This is really important when we think about this. We do not want to confront these patients. They are confused. They don't know what's going on. Sometimes they don't even recognize their family. And so they don't, they're fearful. So yelling at them or confronting them is not going to do anybody any good. They may just lash out. So we need to remain calm and try to work with them. Remember, sometimes when the dementia hits, they revert to very bad habits like name calling, spitting, scratching, and this is just something that we need to be aware of. They're not going to stop their behavior. We just need to be aware of it and know that it may be happening. We do need to communicate with our patients, with our dementia patients. It's very important that we continue. We just may have to do it in a way that's modified. So your book gives you a whole list of things that you can do. Limit distraction. Make sure that you're approaching the patient from the front. Always introduce yourself. Establish eye contact and identify them by name. Always act like you're friendly. Smile. Because if you come in grumpy, you never know what is going to trigger with them. So you need to be careful. Simple language. Nice, short, simple language. You've got to be patient. Again, it takes a little while for these patients to formulate their thoughts. So you need to give them the time to do that. Don't confront them. Don't get angry. Please don't try to reason with these patients because it really isn't going to work. If the patient doesn't understand what we're saying, try to rephrase your question. Don't just repeat it because apparently they didn't understand it. So maybe putting it in different words would be a little bit easier for them to understand. I love this one where it said offer suggestions instead of corrections. You know, with people who have dementia and Alzheimer's, they sometimes forget their family members. And so if that patient mistakes her brother for someone else, don't be critical and say, now come on, you know that that's not that person. This is so-and-so. You can say, you know, I think this is your brother, Gordon. So trying to just be more positive and just help them try to trigger those memories. All right, next group is patients who are depressed. And this can be for a number of reasons. If they're going through the process of dying, we know that Kubler-Ross, and we'll be talking about that, and her stages of death. We have a lot of people that are clinically depressed. And clinical depression is different. It is actually a mood disorder that causes persistent feeling of sadness and loss of interest. I always remember the commercial with the dog that wants to play, and it just sits there and it drops the ball, and the man's just so sitting there so sad. There are people that have can get depressed over a certain situation. You know, somebody dies and, you know, they're depressed for a short period of time. But clinical depression is something that is treatable, and we want to work with the patient. One of the things we want to do is always offer hope. We want to say, I'm here for you. You know, no, we're always here. I'd be happy to listen. You know, we don't tell them to cheer up. We don't tell them to buck up and feel better. We work with them and their medication until they're feeling better. If they're trying to talk and it really looks like they're thinking about sharing something, please be patient and allow for that silence, because that patient is thinking about disclosing information, and sometimes they need to build up the courage to do that. Anxious patients, we want to maintain calm. I don't know if you've seen anybody who's had a panic attack, but it is scary. They are truly so frightened. They're hyperventilating. A lot of them will go into the fetal position. It is a really scary thing. So the most important thing for us to do is remain calm. I'm not saying on the inside you're not going to be a hot mess, but you have to maintain that facade of calm while you're working with them. We're going to monitor that anxiety level. Hopefully we can decrease it. I do a lot of breathing with my patients that are stressed and anxious. I actually do it with them, and I'll go, okay, let's breathe in through your nose and out through your mouth and blow out. I don't explain to them it's actually the vagus nerve that's being triggered and helps bring that anxiety down. There's a physical reason I'm wanting to do it. But if we can get them to focus on their breath, then the anxiety of whatever, you know, the issue of whatever they were anxious about is now in the back of their mind, and in the front of their mind, they're thinking about their breath. Please keep the message simple. It's very important that we just work on them and let them know we're there for them, and use feedback to check their understanding. You know, they are not there mentally if they are anxious. So there's a lot of times they don't hear a thing we're saying. So we really need to make sure that they're following up. We're following up to make sure they understand. Hearing impaired patients, again, observe their behavior and check for understanding. And because of one of our students, I am learning the difference between hearing impaired and deaf. And there is a difference. People who are born without hearing are considered deaf. Hearing impaired is they have lost some of their hearing. And again, as we get older, losing hearing and needing hearing aids and those type of things. One of the things we need to do is you need to speak slowly. That is really important because if they read lips, you need to speak in a slow, steady voice. The other thing that we need to think about is making sure our face and our mouth are facing the patient. If we're talking to them with their back turned, they're not going to hear us. So we need to make sure we turn around and we're facing the patient when we're talking. If there's a lot of noise in the background, it actually can make hearing more difficult. Please don't shout. Shouting is not going to make a difference. If we're going to be changing what we're doing, maybe we are going from the vital signs to getting them ready for an exam, or you're going in, let's say you're a phlebotomist and you're going in and you're identifying the patient and now you're going to go to stick them. You just need to let them know what you're doing. So, question number 8. When a listener leans forward and turns his head, this may be a sign of what? Hearing impairment, visual impairment, or inability to understand English. So, if our patient or the listener leans forward and turns their head towards you, what would that be a sign of? Hopefully you guessed hearing impairment. And you can actually watch patients who have difficulty. They'll say, this is my good ear, talk in my good ear. And they'll actually turn their head towards that. So watch for that. Let the doctor know. We had this conversation in one of our Zoom sessions that there's a number of reasons people don't get hearing aids. Some may be vanity reasons, but the other thing, they are extremely expensive, and Medicare pays hardly anything, if anything, towards the hearing aids. So people don't have that $5,000 to be able to purchase hearing aids. So we just need to be patient with them and figure out what we need to do. Visually impaired patients, again, we're going to announce our presence. They can hear us, they just can't see. We're going to identify ourselves. We're going to let them know what we are doing and what they can expect. Remember, a patient who has sight sees us moving towards them. A patient that is visually impaired doesn't. So if all of a sudden we grab their arm, that's going to scare them. So we need to say, I need to take your blood pressure. So I'm going to go ahead and grab your arm and put the blood pressure cuff around it and let them know step by step what we're going to be doing. Okay? We let the patients know if we're leaving. Don't just walk out of the door because they don't know if we're gone or not. And that can be scary for them. The other thing we want to make sure of is if they are older, we are not going to leave somebody sitting on a high table without some type of supervision. If there's a family member with them, fine. But a lot of times we will leave the older people and people that are visually impaired in a chair. And then once we come in with the doctor, we help them up so we can help them during the exam. What we want to be able to tell them too is the obstacles that are in the way. Sometimes people will use the cane and they can feel obstacles. Some people have dogs that are service dogs, but I always tell my patients, there is a doorway that we're going to be turning left into in about 10 steps. I also sometimes use the clock as a reference. So if you need anything, your chair is sitting here. If you go to the 3 o'clock, if you look at the clock, the door is at your 3 o'clock. There are to your left or to 9 o'clock is, there are your clothes. So give them an idea of where things are located. Speech impairment. I love the pantomime. We really looked stupid when we did that. I just can't tell you that enough. We laugh now, but boy, did we look silly. We can use pantomime and gestures. A lot of times people will just write or they'll use pictures, depending on the age. So it really just depends. There's communication boards that are out there. They're starting to use iPads and technology. We've seen that a lot with autistic children or children with autism, being able to communicate using technology. So when we're, again, working with some of the patients with speech impairment, they can be a number of reasons. Again, they could have had a stroke and they're just learning how to talk. Again, aphasia is the word that we use when people are having trouble speaking and using the correct words for what they want to say. But we can ask yes/no questions. Sometimes that's a little bit easier for them to get out very short answers than having to formulate a whole sentence. Dealing with angry patients, the one thing that we have to remember is we never want to get between the patient. We always want to be between the patient and the door. We never want the patient to be blocking our exit. So let's say you walk a patient in and the seat is to your left. You are always going to make sure that you have the ability to be able to get out of that room quickly. You never want to put yourself on the opposite side of the patient where they have much more control over the situation. We don't respond to them in an angry voice. We try to remain calm and courteous. Boy, I can see you're really upset. Let's talk about what's upsetting you and see if I can find anybody to help you. Again, they're angry about something, and maybe we can help them with that. If there is nothing we can do to calm them down, that's when you go get the office manager and the physician and say, listen, this guy is really angry. And there's times that happens. We see that a lot in our pain management clinics. Patients are mad because the doctors aren't giving them pain meds, and they can get angry and physical. So we have to be very careful when we look at those type of things. Make sure you're very aware of your body language. Don't let them see fear in your face. Don't let them see disgust or anything like that. Remain calm. Again, your face has to be professional, whether it's good or bad. Try to answer any questions. If you can. If you can't, be honest. Say, I need to find somebody else to higher up than me that has to answer that question. I'm going to go get them, and we're going to be right back. Would that be okay? Right? And the worst case scenario is if they don't settle down, we either call security if we have that available, or we call 911 and have the police come in. And that's happened. It absolutely has happened. So we've talked a little bit about that. Patients that don't speak English, we certainly can empathize with their situation. Smile, just smile. Act like you're enjoying yourself. It is so frustrating. Don't let them see that frustration. Try to see if anybody is with them that can interpret. The one thing we want to try not to do is use a child as the interpreter, because then we have personal information about a parent that might be coming out in the discussion that the child really should not be privy to. So we have to be kind of careful with that. Again, if we can find somebody that translates, that's great. If we can't, there are always services. Right now we're using a sign language interpreter with our online students for people who have hearing impairments or who are deaf. And so there are interpreters for language as well. And so while it would be great to have somebody that was proficient in sign language, you just really aren't going to find it. So sometimes it's those services. We just have to get technology, through technology, and provide those services for our patients. We are required by law to have that interpreter there for the patient. It is not the patient's responsibility. It is ours. Okay? Again, we can use pictures if necessary. We can write a message, but if they don't speak English, I'm not sure how good they're going to be at writing as well. Telephone communication is so important. I can't tell you enough. The first line, that person that's sitting at the front desk is the most important person in that office because they are the first person that the patient interacts with. So if you have a crabby Appleton or a nasty person sitting behind that desk, people are not going to have a good experience in that office. Part of my job is going out to the clinical sites and talking to the sites and checking on the students and some of those things. And I can tell you, when I go into an office and the person is sitting there with their back to me, first of all, you should not be doing that. You should always be able to see, people coming in and out. And I can hear her talking about what she did the night before. So it's a personal call and she doesn't even acknowledge me. That really irritates me. What we should do is, if we're on the phone with a patient, that's okay. What we can do is we can physically tell them. They can see we're on the phone. So what we're going to do is just hold our finger up and mouth the words, "I'll be with you in a minute." That's all we need to do. And they understand that. We're going to greet them with a smile. That is much better than having a back to me and nobody acknowledging me whatsoever. So that is extremely, extremely important. You need to be friendly. I am going to stick a video up if I can find it. I've been struggling to find it, about a situation that was not a good interaction. And it is a hoot. It just makes me laugh because they are crazy people. Patients react differently, but the way that the office staff responded to this patient was horrible. So I'm still trying to find it, and I'm hoping to post that. I'll let you know if I find it. Again, we want our voice to have personality. We don't want to go, "Welcome to this office." We want to say, "Welcome. It's so nice to have you here today. Can I have your name?" We want them to feel welcome. The other thing with a telephone, if you smile before you answer the phone, your tone actually changes. So I want you to try this. The next time you answer your phone, I want you to smile and see if you can tell a difference on how you answer that phone. It really does make a difference. So, again, don't chew gum or eat when you're on the telephone. All of that wonderful stuff. We know that's not going to happen. The other thing we have to be incredibly careful about when we're talking on the telephone is releasing information. With HIPAA and high tech, we have to make sure if we are releasing any information, including the date of an appointment, it has to be the patient that we're releasing it to. So they have to identify themselves. It's very, very important. We don't want to fight in the office. We don't want anything. I've seen people at odds with their in-laws or their family, and they want to be there, and the family wants to be there, and the patient doesn't want it, and it can just get ugly. So please be very careful. If you're on the phones, make sure you're identifying the patient and making sure it's them when we're releasing the information. Patient education is something that we do almost every single day. Patients may want information, and anybody can do this. They may ask you at the front desk. You may be, as a coder and a biller, the patient calls and is asking a question about their bill. You may be doing a little bit of education to the patient about what happens. So we are always trying to teach people things daily, okay? One of the things with patient education that we're seeing is there's on the increase because, again, our hospital stays are shorter and people are required to take care of themselves more than they ever have been. So we need to make sure that we are following through, teaching them what they need to know, and also make sure they understood what we just said. So again, we talked about the injections, the insulin injections. Let's say it's wound care. They've got a nasty cut on their hand. And we're going to say, now in 3 days, this is what you're going to do. And you tell them step by step. We're going to ask them, okay, now go ahead. Tell me what you're going to do in 3 days. And then they can walk through it with you. If they don't have it, then we can help them remember that a little bit. It's always nice to send home step-by-step instructions as well, because not everybody has long-term memory and good short-term memory. So it really is important. It gives you on the bottom of page 353 some examples of patient education. Again, promoting wellness, preventing illness, restoring your health, and improving our coping skills. Okay, so what we're going to do is we're going to set our educational goal with our patient. We are going to deliver we're going to create an instructional method, or message. What do we want from this patient education? We're going to go ahead, deliver the instructions, listen to any questions the patient has to ask, check the patient's understanding, and then evaluate. Did they learn it? If they didn't, what do we need to do to make sure they understand it before they go home? Group presentations. I know this is a favorite thing for most of you. Everybody loves getting up and talking in front of people. Being sarcastic here. This is one of the things that scares students the most. And I love it. I love to get up in front of a group of 500 people I do not know and just talk, because I'm never going to see them again. So I love doing presentations like that. But you may be asked to do something like that with patients' families, maybe at a professional meeting, maybe co-workers at a staff meeting. You may take turns doing professional development to get CEUs, those type of things. So what you want to do, and you all have to take speech, so you will be learning this in much more detail. But again, what you want to do is you want to make sure that they understand what they're going to learn and what are the important points. What does the audience need? Are we talking to family? Are we talking to healthcare providers? Are we talking about patients who have a certain disease? We really need to know that, because what we're going to say and how we're going to deliver it will depend upon our audience. So it's really important that you know your audience. Organize the materials and prepare your notes. And yes, I always have notes. You need to make sure you speak at a regular, moderate rate. A lot of times when we get nervous, we tend to increase or talk so much faster. And you want to make sure you're looking at your audience. One of the things that somebody told me when I took my first speech class is imagine that everybody's in their underwear out there. And I love it, because I personally don't even have to do that. I just like to look around and see what people's hair looks like, what clothes they're wearing. I just really enjoy that. But you want to make sure you're connecting with the people that you're talking to, because it makes it a much, much better presentation. And gossip. We're going to end with gossip. I've got one word. Don't. Gossip is one of the worst things that happens in a medical office, and you do not want to be in the middle of it. Gossip sucks up time and energy, and it is something that you just don't want to get involved in. So what I tell people is what I have physically told people when they've come up to me and tried to get me involved. I've looked at them and said, you know what? This is not the time or the place to be able to be discussing people's private lives. first of all, I'm very busy and I need to tend to my patients, and you should be too. So please don't be sharing this, and please make sure that you do not include me in it. And it usually takes care of the situation. You can try to explain the unfairness. I try to do that inappropriateness to say, listen, we're paid to take care of the patients, not to gossip. We shouldn't be doing this. And half the time it's not true anyway. So we're passing on falsehoods, and it only hurts people. So please, please don't get involved in gossip. It's hard sometimes. I'm not going to lie. It's hard, but you need to make sure that you just don't get involved. Patient privacy. The thing that we need to remember is we do not talk about our patients in public spaces. We don't talk about them in social conversations. And we don't discuss patients in front of other people if they're not going to be included in the conversation. So it's really important, again, maintaining that privacy. Just watch what you're saying. Elevators are a killer. Lunchrooms are a terrible place where things are disclosed. Please be very, very careful, because this is the number one fireable offense in healthcare, and that is breach of HIPAA. So please be very careful with that. And we're done with chapter 16. If you have any questions, let me know, and we will see you later.